Okay, go ahead, Dr. McGrath.
Okay, thanks everyone who's able to join us tonight. We have a special episode of Spine Time here focusing on surgery on soft bones. And this is one of the topics that working in a multidisciplinary center like the one that we have at Weill Cornell Medicine really enables us to focus on reload, because we have colleagues that we can tap into, like Dr. Joe Lane, who's joining me tonight to talk about the risk factors of osteoporosis, what it means for spine surgery, how to prevent it, how to manage it, and how to safely navigate spine surgery, back and neck problems as someone living with osteoporosis. So let me just advance our slide here. We'll go right to this slide. So Dr. Joe Lane, he's going to be talking with us tonight about bone health and soft bones. And he's probably the most qualified person in the country to be talking with us about this topic. He's currently the Associate Director of the Orthopedic Trauma Service at New-York-Presbyterian Hospital. He's published extensively on bone biology, tissue injury, repair, trauma. He's a past president of the Orthopedic Research Society, the Musculoskeletal Tumor Society, and the chairman of the NIH Orthopedic Study Section. So in terms of someone who understands the history and the development of the science of bone biology and the treatments that are currently available for it and the treatment of patients with it, Dr. Lane is basically the international authority on this topic. So I'm honored to be talking with him tonight about this, because this is one of the things that comes up in almost every single patient that we talk to who's going to have a fusion surgery, someone who has trauma, or someone who needs just a minimally invasive surgery. It enters into every discussion that we have with patients, is their bone health and how it's going to impact their treatment options, how it's going to impact their day-to-day lives, and how to navigate that as a patient and as a spine surgeon. So Dr. Lane, thank you for being with us tonight. It's an honor to share the panel with you. And I'll just open it up to you, and then we'll go into some questions, hopefully as we go along. And then at the end of the presentation, I'm sure I'll have some questions. And then the viewers are also able to ask questions during the course of the presentation, and I'll try to find those and get to those as we're both talking. So Dr. Lane, thank you so much, and take it away.
Thanks, guys. So we're going to have a little fun tonight. And we're going to talk about what constitutes spinal management when a patient presents with a risk of a fracture. Basically, we're talking about people with osteoporosis. Right now, there is concern on the part of the spine team to do surgical procedures on people who have osteoporosis. And what I'm going to do is try to show you what osteoporosis is, who gets it, what the risks are, and show you that today we now have tools that will enable you to have the advantages of spine surgery when indicated, and have better results. So we'll go on to the next slide. So normal bone, none of the bone that any of us have today was here 20 years ago. In a child, it's turned over every 2 years. In a person around 40, it's maybe every 10 years. And then for a person like who's in their 70s or 80s, whatever it is, it could be every 20 years. But none of your bone is permanent. And the body recognizes that and removes the bad bone that has defects in it by whatever mechanism it recognizes it, removes it, and then it brings in cells that will form bone and will replace it. Now, after the osteoporosis recognizes this, and in osteoporosis, there is removal of bad bone and formation, but unfortunately, it is no longer coupled. So as you turn over the bone, you always replace it with less bone than you started with. Next slide, Lynn. So that is you end up with a thing with less bone. Now, there are many ways to determine less bone. One of them is you can do a bone density. And another one is there are other tools that we can measure your bone mass. But the Dexa, which measures bone mass, does not necessarily measure bone strength, because the strength of the bone is related to two components. One is the amount of bone and the quality of bone. And the quality of bone is made of mineral and is made of collagen. If collagen is not good, your bone is weak. If the mineral is inadequate, it's weak and also. But there are other factors which play a role. And the best way to determine your risk factors are to look at a tool called the fracture risk assessment tool, the FRAX. This was developed by a guy named Kenneth, and it comes out of the World Health Organization based on 9 enormous series of studies, and it looks at and will rate your risk of getting a fracture. For instance, it looks at age. Age accounts for 30% of the risk. Older people, greater risk than younger people. It looks at women versus men. Women have a much higher rate of problems than men. Women and men start with more bone than women. For men to get into osteoporosis, they have to lose more bone than to get into a vulnerable spot. Women don't have to lose as much bone. They look at your weight and your height. You make estrogen in 2 sources of your body, your ovary and your body fat. People who do not have body fat, when you enter menopause, you have no source of estrogen. So basically, thin people are at much greater risk than chunkier people. And the healthiest people are not 90 pounds. They are 120, 150. Those are the healthiest bone-wise. It's related to your genes. So do you have and to what you have done. He who, if you've had fractures, it indicates you're going to get more fractures. So previous fracture increases your risk. And if your parents had fractures, they increase your risk because you get your genes from your parents. And then there's social issues. Are you a smoker? Smoking will profoundly affect your bone and also will make it difficult for drugs to correct it. Steroids. Every time you get a steroid epidural injection, you lose a little bit of bone. I'm not stopping epidural injections, but you should be protected if you're going to be getting steroids for whatever reason. Autoimmune diseases like rheumatoid arthritis increase your risk. And then there are a whole array of other diseases out there. And of course, among men, the number 1, 2, and 3 cause of osteoporosis is too much alcohol. You can have your drink, you can have your glass of wine. I love great wine, but reasonable amounts, not unreasonable amounts. Now that will set up a risk chance for you. And if we do a Dexa, we can refine that better, but we don't need to do a Dexa to make this answer. So your homework tonight is to look up FRAX and look at your risk. And if you have a 3% chance of getting a hip fracture in the next 10 years, or a 21% chance of getting a long bone fracture, you should be treated. You should be treated. So look at it yourself. And if you are in that zone, lickety split to your internist and get yourself under control. Next slide.
Dr. Lane, real quick question for you. Just in talking about risk factors, how does a sedentary lifestyle play into,
exercise?
Risk factor?
That's right. Now, your bone will respond to exercise and will strengthen the bone in the areas that are under stress. So if you do a reasonable amount of exercise, let's say 1 hour of real significant exercise 3 times a week, or you do not quite intense, but you do something every day, like you walk a couple of miles, or these kind of things will be noticed. They will not increase your bone density, but they will lower your risk of falling and getting a fracture. So people who exercise have lower fracture rates than people who don't exercise. If you want to make bone, you really have to do exercise. Now, it's almost impossible to do what you have to do. We're talking 6 hours, 5 times a week. There are people who do this. Dancers do this, professional dancers. They rarely get fractures. They have other problems, but they can make tremendous amount of bone with significant exercise. So exercise is good for preventing fractures, but if your bone density wants to increase, you're really going to have to do serious exercise.
Interesting. Okay.
Now, again, bone is made of collagen. Bone is made of mineral, and the mineral is calcium. So most people who have fractures have low calcium levels and have low vitamin D levels. From October to April, sitting in the sun is useless because New York is too high up and the sun is too low on the horizon. And so this is a particular problem. So the only way to solve this is for you to take calcium, vitamin D. We prefer to do it in your diet, but there's very little vitamin D in your diet unless you eat salmon every day or cod liver oil. So vitamin D, you need to take about 2,000 units a day. You're not going to get into trouble. That'll take care of you. Calcium, look at your diet and try to get 500 milligrams of calcium. If you really have a bad diet, you may need a higher calcium, and there are ways to adjust that. But everybody needs calcium and vitamin D. And in terms of your collagen, you need vitamin C. C cross-links it. So people who are very flexible, flat feet, overextend their elbows, their skin, you pick up the skin and it doesn't go back down. These people have a collagen defect. They need vitamin C in their diet. Let's go on the next slide.
Dr. Lane, I'm glad you brought this up because, I think the data shows that about 30% of patients undergoing spine surgery have low vitamin D levels. And it's something that we don't really check that often, but it's probably something that we should check more often and that we should be supplementing our patients with.
Well, absolutely. I think if you're going to go into some procedure that is going to do musculoskeletal repair as necessary, you should get your vitamin D up. It does a lot of other things. It was around before we had phones, so it has other purposes. And it's been shown that people who are vitamin D complete either don't get COVID, or if they get COVID, they get a much milder form of COVID. We just did a study on employees in our hospital, and those people that have bad vitamin D had a much worse case. So I think it's just for selfish purposes, get your vitamin D up. That will help.
Fascinating.
Now, there are many drugs that treat osteoporosis, many drugs. And the way all of them will decrease your risk of getting a hip fracture and a spine fracture. They all work equally. However, some of the drugs will actually add to your skeleton, and some of the drugs will just keep your skeleton stable. That's one thing. Number two, some of them will make the bone heal, and some of them have no effect on bone healing. Now, the drug that is the family of drugs that will make bone heal and have been shown in the spine application are what we call PTH drugs, which are Forteo and Tymlos. And here is a study which was just done on pelvic fractures, which is part of the skeleton. And what they showed is that if you look at the function, which is down over, I don't know if you can see my figure down here, near the CSPP. This is your ability to walk, your walking speed at 4 meters, the ability for you to getting up and down from a chair, and your balance capacity. it was dramatically better in the patients with pelvic fractures who took Forteo. Dramatically better. And the group in Austria showed that the time to healing was cut by 50%. It was 50% faster if you took these particular drugs. So that in areas of fractures of the spine, there is no question that the Forteo and Tymlos, which is the other drug, will dramatically increase the speed at which you heal your fractures. Next slide. Next slide. Can you change Lynn? Next slide. Okay. But the best studies all come from Japan. And what they did is they looked at spine fusion. And what they did is they compared, there are 3 family of drugs. Do nothing, just calcium and vitamin D. Take the PTH analogs, which are Forteo and Tymlos, or take bisphosphonates like Fosamax and that family of drugs. And what the PTH analog showed, the failure rate after spine fusion was cut in half by taking a PTH analog. The other thing, today, when most spine surgeons operate, they put little hardware in there to try to hold the spine. They put pedicle screws and other instruments. And these screws can be pulled out. And what they showed is that the PTH analogs had 50% of the rate of failure of these screws compared to the control population, and that the bisphosphonates, Fosamax, and those other agents are no different than control. So that bisphosphonates will do lots of things, but they will not help spine surgery. They won't hinder it, they just won't help it. But the PTH drugs will unequivocally improve the results of spine surgery quite effectively. Next slide. And there's a study in spine most recently, which confirmed once again the Japanese data, but this came from Spain, that the teriparatide, which is the PTH analogs, dramatically and significantly improved the spine fusion rate compared to bisphosphonates and control. Now there is another drug that is out there, which is commonly used. It's called Prolia. Now, Prolia is an injection once every 6 months. And this was a cancer drug. It actually is very successful in helping people handle breast cancer and other kind of cancer drug issues. And what the Japanese did is they used this agent in spine fusion. And what they found is when you put screws into the spine, when you take denosumab, you form a extensive ring of hard bone supporting the screws. And so that the hardware is markedly improved when you take denosumab. So we now have 2 family of drugs which will improve spine surgery. One of them are the anabolic agents, Forteo and Tymlos. And the second one is denosumab. Denosumab will not enhance the amount of fusion, but what it will do is the hardware will remain fixed and will not loosen when you take that drug. Next slide. So looking at all the drugs that are out there, some make more bone than others. And then when the spine surgeon comes to a person and says, we would like to fix your spine, but boy, you're osteoporotic, I really wish you had a little bit more bone going into this operation. Some of them can help. So let's take a look at what these common drugs are, how well they help. The bisphosphonates, Fosamax, Actinone, B-class injections, they will not add any new bone. You got what you got, what you got. Denosumab, which is also Prolia, will increase the bone 3 to 5%. The 2 PTH analogs, Forteo and Tymlos, will increase the bone about 10% in a year. And romosozumab or Avidity, which does not help fusion, but will increase your bone mass 15% in a year. So if you took Romo or Avidity, you could increase your skeleton a very large percent going into spine surgery. So if you're undecided about spine surgery, you're considering it, but you're not yet ready, and you take a look at your bone mass and it's low, they could put you on a drug which will dramatically increase the amount of bone in your skeleton. So it is possible. Now, if you want to have some meaningful treatment, the PTH analogs 3 months before surgery will increase the pull-out strength of your screws by 38% with just 3 months of treatment. So you don't need to treat for a very long time to get some benefit. It depends on the amount of time that you have. But for the patient who's considering spine surgery and not quite there, they should be getting their skeleton in position for when they get the surgery. Next slide. Now, where are we going into the future? Well, in cancer, in the old days, they used a single agent to treat cancer. Not so successful. So they learned if you mix things together in a combination, you may get the benefit of mixed drugs. The same thing is now going on in osteoporosis. So they've taken PTH analogs such as teriparatide, and they mixed it with denosumab and gave both at the same time. And doing both at the same time compared to teriparatide, they dramatically increased the rate of fusion and dramatically increased the amount of bone density in the femoral neck. So combinations of these drugs are the wave of the future, and they in fact can even make more bone than romosozumab. So we are raising the potential to rebuild your skeleton very, very quickly by using these combination drugs. Next slide. So you're thinking of a spine fusion. Pre-treat for 1 month with one of the anabolic agents. Your pull-out strength will increase. And then following the operation, take these anabolic agents. You can take it for 3 months, it helps. If you take it for 9 months, it does a better job. And if you're osteoporotic, you should continue it for 24 months. So what we're saying is, recognize if you have osteoporosis. Recognize it. You should start working and fixing it as quickly as possible. And we have the capacity to take a person with osteoporosis and make them normal. Now, some drugs will not do that, but selective drugs will bring you back to normal. If you've had a fracture, beware, and you should be under treatment. And then when you go to the physiatrist to get epidural injections, every epidural injection is going to lose a little bit of bone. So when you're getting the epidural, you need to be on a drug to prevent that from occurring. And we have many drugs which will protect you while you're getting epidural injections. If that fails and you're now cruising for some spine surgery, we have a program. If you have more time, then we can get your skeleton back to normal with romosozumab or Avidity. If you have less time, we should definitely treat you with agents to ensure that you have a more successful procedure. So we live in a new world now, and we should set up algorithms for this. We have very strong data supporting every one of these statements, and it's just beginning, and we're going to get better and better as time goes on. But I think the biggest thing is that the patient has to be an advocate for themselves. So when you talk to the doctor, you say, if you're going to consider fixing my bones and do something with my bones, how good are my bones? And what should we do to make them better going into this little interaction between us? And I think we have now pretty much covered what I wanted to say.
Dr. Lane, that's Excellent overview. Thank you so much. One question that I had myself, and it looks like some of our audience members are having, it's kind of a twofold question. Should everyone just take these drugs before spine surgery? And I guess the related question is, what are the side effects? What are the downsides to taking these drugs? All
right. So certainly my biggest effort is to try to get them in the hands of the people at greatest risk. So that's no question. If you have a FRAX or a score that shows you're osteoporotic, absolutely should be taking it. Questions I can't answer is, will it help everybody get theirs? And we're looking at what we call osteopenia. We are now studying that at our institute in our group. And I do believe if you're osteopenic, it would be to your benefit. But if your bone mass is absolutely perfect, then the question is, are you going to make too much bone? And I'm not so sure it is safe to use these agents with a lot of stenosis in a person with extensive skeleton. That may not be the right answer. So I think it's in the hands of the surgeon. Is there a problem with this? And if you're unhappy when you get in there and you put your screws in, they don't hold, and there's some evidence that the bone is softer, then I would use it. And you can certainly catch up after the operation and protect you. But they're going to have to be thinking, is this soft bone? So I wouldn't do it, but I would put everybody on calcium and vitamin D and vitamin C. That I would do. So regardless of what's going to happen to you, you should be on calcium, vitamin D, and vitamin C. That's just the right thing to do and the healthiest thing to do.
Another question is, is this something that I always quote that I think 20% of people over 70 have a vertebral compression fracture of some sort. Whether it's symptomatic or not is a different story. But is this something that after a certain age, even if you're not having spine surgery, if you should be taking this scale, doing this questionnaire, finding out your risk, and going on something like this? Are there benefits to trying to normalize your bone density and your skeletal health, even if you're not going to be looking at going into a spine surgery, just to prevent something like a vertebral compression fracture?
Well, absolutely. The most common fractures we have are vertebral fractures. 50% of vertebral fractures are silent. Somebody takes an x-ray and say, when did you fall down? When did you get this fracture? It happens slowly. The bone just sort of crunches down, and you may end up with a fracture that you didn't even realize. Normally, you will lose 2 inches in height as you get older, just because the discs will narrow. If you get over 2 inches in height, then it's either a fracture, scoliosis, neuromuscular disease, or the bones are slid off. And the doctor should make that determination, but certainly you should be very curious if your bone height, if you've lost a lot of bone height, because that could be silent. And certainly if you get a fracture, you have 5 times the risk of getting another fracture compared to somebody who doesn't have a fracture. So any silent vertebral fracture should alarm you, and you should be put on therapy immediately for that. And now,
the other question I had is, what's the best, for a patient who's out there who's not necessarily at a comprehensive spine center, what's the best kind of a doctor for them to see that would be familiar with these kind of regimens? Would their PCP be able to prescribe these things? Is an orthopedic surgeon, an endocrinologist? What's the best way for people to get on a regimen that's being managed by a physician?
Okay, the first thing I would do is I would talk to your primary care doctor. Are you watching me for osteoporosis? And are you comfortable watching me? If you are sympathetic that it should be evaluated, that means any woman over 65 should be evaluated. Any man over 70, anybody with low energy fracture over 50 should be treated, should be evaluated. So that's the first thing, is will he or she take care of it? If they're uncomfortable, the best people are to either go to a rheumatologist or to an endocrinologist. An endocrinologist or rheumatologist would be your next best. Now, of course, In women who are younger in issues, the OBGYN, in theory, should be knowledgeable about this too. But I think you're going to get more bang for your bucks either with a rheumatologist or with an endocrine type person. And that would be the first place. And they could put you onto a program which is going to work best to protect you. But most internal medicine people today who take care of older people are aware of this. Certainly it's true in New York. And they are paying much more attention to it. Their problem is it's a little bit more complicated. When patients have an array of different diseases, they may need to have a consultant set the stage for them, and then the primary care doctor can run with the ball.
Okay, thanks, Dr. I'm just going to go into some of the questions from the audience here. One question that came up that I also wonder about is, when you're adding bone, is there a difference in the character of that bone? Is there a chance that the bone that you're adding is more brittle, or is that bone functionally the same?
Well, the first bone you put down is immature bone. So the initial part is immature, and it needs to be remodeled according to lines of stress. So you need to have a program of exercise to tell that bone to be made in the right direction, in the right alignment for that. But once about a year or so after that, that new bone becomes very healthy, but it should be removed. Now, if you're taking medicine and you're not removing the bone, it will become brittle with time. So healthy bone should be around for a certain, let's say about 10 years, and it should be replaced. If it's around for 20, 30, it becomes brittle. So the drive to replace your bone is through exercise. You raise the question, should people exercise? Yes, get a stepwatch. Count your steps. Do something, walk places, get onto a bicycle, go to a dance class. Bar Pilates are fabulous for getting people into a program. You think swimming won't help? Swimming helps because it makes the muscles better. And do things that will improve your balance. If you cannot stand on your leg for 12 seconds, you have a balance problem. And then you need to go to a physiatrist who can set up a program for you to improve your balance. So you can't get a fracture unless you fall. And if you can't stand on your leg for 12 seconds, you're going to fall. You are absolutely going to fall.
Dr. Lane, a couple questions about some specific formulations here. What do you think about Zelronic for bone?
Okay, so the bisphosphonates are very successful in protecting your bone, and they are usually the last drug you take after you've had a treatment program, because they will seal the bone. They stay in your bone for 60 years. But if you take too much of it, it will cause brittle bones. And so people who are having major dental work, if they're on bisphosphonates, they have to come off the bisphosphonates when the dentist is doing their dental work. That is the biggest problem we have with these agents. And if you take them aggressively for over 5 years, you can get a brittle bone in your thighs, and it's called an atypical fracture. So it's a remodeling problem. Now, Zelronic acid is the most effective. Pills are unreliable compared to intravenous. When you get an intravenous, you get what you get. But the difficulty with Zelronic acid, it should not be taken in patients with significant renal disease. So renal failure, they have to cut the dose or use a weaker agent. So those are the Zelronics. What's wrong with Prolia? Prolia is an extremely safe drug. It's an antibody, and it works by turning off the signal in bone. It's a very safe drug to take. However, it too will affect your jaw when you're having dental work. So you should do your dental work 2 months after you get Prolia. The Prolia must be done every 6 months. You cannot miss a dose. And when you come off it, there's a rebound. So you need to cover it with Zelronic acid when you come off the Prolia. But it's an extremely safe. When the French looked at all their drugs, They said Prolia was their safest, best drug to use in their country. The anabolic agents are parathyroid hormones. So if you've had kidney stones, you have to be careful. If you've had radiation, you cannot take the drug. And it raises your calcium, so you have to monitor your calcium. And the final drug is Evenity or Robo, and Romo should not be taken if you have had a recent heart attack or you've had a recent stroke. You should avoid those drugs because your recovery from them is compromised if you stay on Romo. And I think if you get up to be 85, maybe you should really think before you take that drug. Talk to your internist, your cardiologist, is it safe for you on that drug? But all the drugs, all of them will give you, cut down your risk of a vertebral fracture 70% and cut down the risk of a hip fracture by 45%. So they all have the same fracture protection, but they do other things.
One question that I get a lot is how long should patients wait before getting spine surgery after they've come off the drugs? Is there a waiting period that they need to prepare for between their regimen of medication and then the spine surgery? Are some that you need to come off beforehand? Are some ones that you can take right on through the spine surgery?
So it turns out everybody's thought that the bisphosphonate, et cetera, would inhibit spine fusion. There is no data to support that concept. So you can go right from the bisphosphonates to spine fusion. If you want to do something to improve your bone, then you should plan in advance. Forteo is less effective when it's near a bisphosphonate. So probably the advantage of coming off the bisphosphonates are the other drugs will work better when you apply them. So probably stop the bisphosphonates a year in advance. Consider taking other drugs to start warming up the skeleton, and then all the other drugs can be used with your surgery, and it should not be stopped. The problem
so it's not that there's a problem with the surgery, it's a problem that some of them that you want to be taking near the surgery are less effective in the context of other medications like bisphosphonates.
Exactly. Now, the only other drug which is a problem one is Prolia. Prolia, if you want to go into an anabolic agent, what I would probably recommend is not stop it, but add the anabolic agent and keep on the Prolia. And this is the combination drug, which is remarkable, absolutely remarkable. So that's the way we handle patients who have been on Prolia, because there's a problem of getting you off Prolia. It's not such an easy little maneuver to do. So that's what I think I would do.
Another question that came up in the comments here is, if you are being treated for osteoporosis, is there like an end date? It seems like some people are being told that whatever treatments they undergo will only last a certain period of time. Is it the type of thing that you need to keep being treated for the rest of your life, or is there a possibility that there was just some deficit that you can make up with a medication or a lifestyle change that then you're treated forever? Or is it a lifelong process of having to be checked and treated and medicated?
Yeah, well, this is in the eyes of the drug companies that want you to be on the drug forever. The bottom line is we will treat you until your bone density, your T-score is -2. And that's a very safe level. At that point, we will take you off your drug, whatever you're on. If you're on a bisphosphonate, we'll just stop it. But the other drugs, we will then shift and give you 1 year of reclast or zoledronic acid to seal the inside and the outside of bone. And then you can come off the drug. And at that point, you can be off the drug for maybe your lifetime or maybe not. Even though it's in the bone for 60 years, it may not work for 60 years. And, about 15 years after you stop the drug, you may need to go back on treatment again. So clearly you can come off the drug, but you got to seal it with a Zelronic acid when you come off the drugs.
I think one last question about Dexa scans and whether they present an accurate picture of bone health. You kind of mentioned it at the beginning of the talk, and you said actually the FRAX scale is more accurate. Is Dexa scan still part of your usual workup, or are there limiting factors?
Yes, we use the Dexa to determine when we can stop the drug. We're looking at your bone density. Now, in the spine, we have a problem. People who have arthritis, their bone density of their spine will be very good because they make a lot of arthritis. So the Dexa is not valid in the spine with arthritis, and it's not valid in the spine when you have a lot of scoliosis. To get around that problem, we do what we call as a QCT, we do a CAT scan. What we do with the CAT scan is we then make a cube of bone in the middle of the vertebral body, and we measure the amount of Hounsfield's units, which are the ways that's what you're counting when you do a CAT scan. And that can be converted to a bone density. So that will give us a better number than the Dexa. But for simplicity in the world, the Dexa is a very good tool to use. It alerts you, it gets you thinking, but it's not the full story. It's not the full story. And the FRAX is better, but it takes into consideration your bone density. But I do think the spine is a challenge to measure bone density in the spine due to deformity and arthritis, and you gotta have to peel into the middle of the vertebral body to get that number.
That's great. It's exactly what we were wondering. I think the last thing is a lot of people asking what dose of. You mentioned a dose of vitamin D. You mentioned a dose of vitamin C. Is there a specific dose of calcium?
Yes. All right. So the safest thing would be to start with 500 milligrams of calcium. 500 milligrams of calcium. You got to read the bottle carefully. The bottle will say, 600 milligrams of calcium. But in the back, it says 2 pills make the 600. So the serving is 600, but there are 2 pills that make the serving. So you have to look carefully at the little table in the back to see what that number is. Start off with 500, start off with 1 dairy product, and eat something green every night. The cow doesn't drink milk. It eats grass and makes calcium for you. So it's in the leafy green products. Unfortunately for the pea people, peas don't count. There's no calcium in peas. But the, lettuce and spinach and, whatever, and broccoli is loaded with calcium. And if you have trouble swallowing the pills, they're pretty damn big, try Bluebonnet. 1 tablespoon of Bluebonnet is 500 milligrams of calcium. Then get your doctor to check the value and correct it. So, but if you're not being checked, 500 is not going to get you into trouble.
I'm going to go home and start taking vitamin D, I got to say.
Do a little exercises, correct your balance, think great thoughts, and kiss your loved ones. And if you're vitamin D deficient, I can tell you your loved ones are deficient too. So that's
I'm sure they are. It's been a long, dark winter. And especially, I think, I know being at the latitude we are at in New York, the sun doesn't make that much of a difference. But I think people being indoors even more than ever with the pandemic, probably we'd see rates going up of vitamin D deficiency the past 2 years.
So coming back to if you are having trouble getting information, we have members of our metabolic bone disease team at Memorial. We have a very strong group at NewYork-Presbyterian. We have them at various other hospitals. And so if you can ask for the bonehead in the endocrine department, and there will be somebody there who can help you. And if you have a problem, you can always contact me and I will get you directed. And we certainly we're out there trying to help the people as much as possible. But I think it's a very exciting period now, and I think we're trying to pick the drugs and the treatment at what's for the problem, not the cheapest. Not the cheapest. Sometimes you pay a little bit more, but we're very good at fighting with your insurance companies to make sure they come to the plate and pay the right and not make it adversarial with you. We're very
that's a big concern, and I think that the more literature, the more these things are proven, the easier it is to get the insurance companies to get on board. So that's great. Any online resources that people can use that you recommend?
They want to learn something, look at NIH. They have a great information group. The National Osteoporosis Foundation has wonderful information that is true rather than a lot of the internet statements. And you go there and it's written for the public. So it doesn't use silly words. It uses straight words that you will understand. And I would go there first if you have a question. And that will be that's the best place to get your information today. National Osteoporosis Foundation and the NIH. The other group may be Own the Bone. Own the Bone is a very good group that also has excellent information for the public. Excellent information for the public.
Well, it's fantastic. I'm already getting a lot of great feedback about this episode. I think it's something that hits all of us at some point in our lives, and we should all be thinking about, but it's hard to navigate sometimes all the options. And so I really thank you for joining us and for giving us the benefit of your experience. And thank you for all the audience for participating and all the great questions. And look forward to seeing you all next time.
Thank you. Thank you, Lynn. You're a great mentor and great moderator.
Thank you. Likewise. And Roseanne is telling me that in the YouTube video, we're going to be posting some of